To increase the chances of survival, we need to have high-performance team. We see a diagram that shows the positions of team members around a patient and describes each person's role within the high-performance team. The team member placement can be adapted to local protocol. In the center of the diagram is a person, or the victim. At the person's head and on each side are the team members who make up the resuscitation triangle. The compressor on the person's right side assesses the patient, performs compressions according to local protocols, and rotates with the monitor defibrillator CPR coach every 2 minutes. The monitor defibrillator CPR coach on the person's left side brings and operates the AED, monitor, and defibrillator and acts as the CPR coach. He alternates with the compressor every 2 minutes. And if a monitor is present, places it in a position where it can be seen by the team leader and most of the team. The airway. At the person's head, opens the airway, provides bag mask ventilation, and sometimes if advanced providers come, they can intubate the patient. No team member leaves the triangle except to protect his or her safety. Elsewhere around the person, there are team members who make up leadership roles. The team leader at the person's right foot, but may move around, assists roles to team members, makes treatment decisions, a role and task performed by advanced providers, provides feedback to the rest of the team as needed. Every resuscitation team must have a defined leader. At the person's left foot is the IV-IO- medication. An ALS provider who initiates IV or IO access and administers medication. IV is intravenous and IO is intraosseous. And finally, near the person's right shoulder, between the airway and the compressor, is the timer-recorder who records the time of the interventions and announces when these are next due. Of course, we're not talking about medication, but when, for example, when we will talk about ACLS diagrams, or I have lots of short videos about ACLS diagrams, there we will use medication, and we need to know the time when we give the medication because the time is fixed, the interval between two medications is fixed. So there should be a person who will record and say us if we need to do the next dose. They need to record the frequency and duration of interruptions additionally and to communicate this to the team leader. We already know, for effective team performance, we need to minimize interruptions in compressions. For that, team must communicate continuously. For example, if the compressor counts out loud, the rescuer providing breath can anticipate when to give breaths. So when I was a nursing student, it was approximately 13 years ago, we were learning the BLS and the first aid, and there we were learning that we need to count out loud, and the counting should be continuous. For example, it should not be 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 1, 2, 3, 4, 5, 6, 7, 8, 9, 20, 1, 2, 3, 4, 5, 6, 7, 8, 9, 30. It should be 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. So it should be continuous. So the person who is responsible for giving rescue breaths or bag mask ventilation knows at what step you are. But here, when we're learning, we are not saying that. It is not a written rule. So if you are alone, you can just not count out loud because you are just going with your pace. You know when to give breaths, and but it is advised just to count out loud or whatever it is convenient for you. And again, let's repeat this one more time because this is very important. Delivering effective chest compressions is very hard work. I remember there was only one case that I did chest compressions approximately. It was 10 minutes, I think. I was all alone and I had no one to, we had with my attending physician. He was like doing intubation. We were in the ICU setting. and I was the only one. And even at one point, my attending physician came like several seconds to help me to do the compressions until I could just catch my breath, and then he went back and to look at the ventilation device, and we were all alone, and other physicians they went for other calls, and thankfully, yeah, we had ROSC, and we stopped. It was not longer than 10 minutes. And I remember that I was all alone, and I know what fatigue means. Chest compression is very hard work, and we need to do that effectively. And if the compressor tires, chest compressions will not be as effective. To reduce this rescue fatigue, switch compressions about every 5 cycles or every 2 minutes or sooner if needed. And additionally, I want to mention one thing here. Of course, this is more from ACLS course, but we talked about when patient can have tracheostomy or endotracheal tube. And especially this happens during ICU setting. These patients who are very severely ill, they have these tubes. They are breathing with the help of the ventilating device, ventilating machine. And we're doing continuous compression. So the device is breathing. Breathing is okay. So we're just doing compressions, and there are cycles. People are rotating, and who is of course, if there are a lot of people, the one who is more proficient, like professional, and it does it effectively, does the compressions, they are switching, but we're not thinking about the ventilation anymore. We're just doing continuous chest compression and medication, compression medication, until we will have ROSC. So we're not doing the head tilt, chin lift, or jaw thrust maneuvers because the endotracheal tube is already in the trachea. So we're sure that airway is open. The chest compressor switching should take less than 5 seconds, and some BLS providers have special training in coaching CPR to help the resuscitation team minimize interruptions in chest compression. This role is called CPR coach. This is a person who supports performance of high-quality BLS skills, allowing the team leader to focus on other aspects of clinical care. And the CPR coach's main responsibility are to help team members provide high-quality CPR and minimize pauses in compressions. The CPR coach needs a direct line of sight to the compressor, so they should stand next to the defibrillator. As soon as the patient is identified as having no pulse and no breathing, the CPR coach says, "I'm the CPR coach," and tells rescuers to begin chest compressions. And of course, which really helps, the CPR coach can adjust the environment to help ensure high-quality CPR. They can adjust the bed rails, lower them, or the bed, get the step stool, or roll the victim, help to put the backboard underneath, place the defibrillator pads. And additionally, coach should give feedback about performance of compressions, depth, rate, and chest recoil. The CPR coach communicates with the team to help minimize the length of the pauses in compressions. Once again, I'm repeating this because this is very important. Pauses can happen when the team defibrillates, switches compressors, and places an advanced airway. Yes, when we're placing an advanced airway, for example, endotracheal tube, we're not doing chest compressions at that time. Okay. From this and next slide, you will have questions during your exam. Team dynamics during a resuscitation attempt include 3 elements: roles and responsibilities, communication, and debriefing. Let's start from roles and responsibilities. Because every second is very important during a resuscitation attempt, it is important to define clear roles and responsibilities. When all team members know their jobs and responsibilities, the team functions more smoothly. Rescuers should clearly define roles as soon as possible, and the tasks should be divided according to each team member's skill level. As soon as the victim is identified as pulseless, the CPR coach will identify themselves and prompt the compressors to begin chest compressions. Next important element of team dynamics is know your limitations. All team members should know their limitations. The team leader needs to be aware of them as well. For example, advanced life support providers may be able to perform tasks that BLS providers would not be permitted to do. For example, medications or performing intubation. Each team member should ask for assistance and advice early before a situation starts to get worse. Next element is offer constructive intervention. Whether you are a team member or the team leader, there may be times when you need to point out another team member's incorrect or inappropriate actions. When this happens, it is important to say it in a very tactful and constructive way. This is especially important when someone is about to make a mistake on a drug or dose or an intervention. Anyone on the team should speak up to stop someone else from making a mistake regardless of role. Next, coaching and debriefing. These are important in every resuscitation attempt. During the event, the CPR coach will help improve performance of compressions and ventilations by ongoing coaching. They also will work with the team leader to minimize pauses in compressions during defibrillation and placement of an advanced airway. After the resuscitation event, debriefing is an opportunity for the team to discuss how the resuscitation went, identify why the team took certain actions, and discuss whether anything can be improved in the future. This can happen immediately after the resuscitation or can be scheduled at a later time. Please remember what each key elements mean in team dynamics because you will see them during your exam. And the last team dynamic element is communication, which includes shared knowledge. Sharing the knowledge that we have is important for effective team performance. Not only it can help assure that everyone is fully understanding the situation, but it can also help the team treat patients more efficiently and effectively. The team leaders should frequently ask for observations and feedbacks. This includes asking for good ideas about managing and resuscitation attempts, as well as for observation about possible oversight. Next, summarize and re-evaluate. Summarizing will help because it will provide an ongoing record of treatment. It's a way to re-evaluate the victim status, the interventions, and the team's progress within the algorithm of care and helps team members respond to the victim's changing condition. 3. Use closed-loop communication. This is an important technique used to prevent misunderstanding and treatment errors. It consists of the sender giving the message, the receiver repeating it back, and the sender then confirming it was heard correctly. To practice closed-loop communication, the team leader and team members should do the following. Team leader call each team member by name and make an eye contact when giving an instruction. Do not assign additional tasks until you are sure the team members understand the instruction. Team members confirm that they understand each task that the team leader gave, and they need to verbally acknowledge the task. Tell the team leader when you have finished a task. The message should be clear. This will prevent misunderstanding and keep everyone focused. All team members should use clear, concise language, speak loudly enough to be heard, and speak in a tone that both is calm and confident. And important element, show mutual respect. All team members should display mutual respect and their personal attitude, regardless of each rescuer's skill level or training. Of course, everyone can have emotions, especially when we're facing something like cardiac arrest, but this is mostly important for a team leader who needs to speak in a friendly, controlled voice and avoid shouting or aggression.